Good afternoon, everyone. Thank you for those of you who are attending in person and also the people who are joining us online, including Dr. Rob Commons, who's going to be presenting from Ballarat today. Before we get underway, I'll just remind you that this is being recorded as well. At the end of Rob's presentation, there's the opportunity for questions. So we will go to some questions in the room first, and we'll also open up to any questions that are online. As we get underway, I'd like to just acknowledge the lands that we're gathering on here today in Darwin, which is the land of the Larrakia people. And I'd like to pay my respects to their elders past, present and emerging. I'm going to hand over to Rob now, who will present the first research seminar for 2023. Thank you, Rob.
Thanks very much, and thanks very much for having me. It's great to be presenting and restarting up this research seminar series. I'm sorry I can't be there in person. One day I will come back to Darwin in person, I promise. But great to have everyone listening in to this talk about what dose of primaquine is best to prevent relapsing vivax malaria. Before I start, I'd just like to reiterate that, as mentioned, I'm speaking from Ballarat in Victoria today, which is the lands of the Wadawurrung and Dja people, and I would like to acknowledge them as the traditional owners here and to pay my respects to elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander people that may be joining us today. So, Plasmodium vivax malaria, many of you have probably heard about it because you work at Menzies, but many people around the world have not. Just because it really is this poor cousin, the second cousin to Plasmodium falciparum, which is the main cause of human malaria around the world. But Plasmodium vivax is the second most common cause of human malaria. And there are around 40% of the global populations at risk of vivax malaria. It causes at least 4.5 million clinical cases annually, probably a lot more, and costs the global economy an awful lot, potentially 360 million. Unlike falciparum malaria, successful treatment, or what's called radical cure, requires treatment of the blood stage, which is the stage of malaria that causes the symptoms, as well as treatment of a liver stage, which are called hypnozoites and lie dormant in the liver and relapse, leading to recurrent clinical symptoms of malaria weeks or months after the initial infection. And unfortunately, there is only one class of drug that we have to be able to treat these relapsing liver parasites, these hypnozoites in the liver, and that's the aminophenolines. We've got two drugs, one which is very old, primaquine, and one which is very new, tafenoquine. Both of them do a good or reasonable job at preventing relapses, but they both have the same key side effect or concerning side effect, which sort of hampers their utility, and that is that they can cause hemolysis in people who have glucose 6-phosphate dehydrogenase deficiency. And I'll talk a bit more about that down the track. I think at this point in time, it's worth noting that the total dose of primaquine, and that's what I'll focus on today, is really what determines the efficacy against relapses. But it's really the daily dose or the cumulative dose, potentially, that is the issue when we talk about hemolysis or side effects. So what dose and what duration should we actually be using? And I've got a little table here, which is a cheat sheet, and these are common doses that are used and common doses that are in research. And as you can see, it's really trying to split it up between how the total dose of primaquine relates to the daily dose. So if we look at the top row, you can see that low total dose over 14 days. So this is a low total dose is 3.5 milligrams per kilogram. And that means that the daily dose is also what we classify as low. It's 0.25 milligrams per kilogram. But if you shorten that regimen and give the same amount over a shorter period of time, over 7 days, then you have to give 0.5 milligrams per kilogram per day instead of 0.25. So it moves up to an intermediate daily dose. Obviously, if you increase the total dose, then your daily dose is reflected in those increases, and that's the third and fourth rows there of that table. So I'll just step you through. So early studies suggested that an intermediate dose, it's 5.25 milligram per kilogram total dose over 14 days, probably had greater efficacy than 3.5 than that low total dose. And this was in what's called the Chesson strain, which is in Southeast Asia, so Indonesia and Papua New Guinea. Saying that, the sort of the biggest early experience from a safety perspective and from an administration perspective was with the 3.5 milligram per kilogram per day over 14 days. And that was with the US military. There was a lot of safety data that came out of that, which really reassured people that this was a reasonable dose to be able to give to people. And because of that, that sort of got taken up by many countries. What does the World Health Organization recommend? Well, it recommends 3.5 or 7 milligram per kilogram total dose over 14 days. 7 milligrams per kilogram, it really restricts to that sort of Southeast Asia, Oceania, where the red circle on the map is, although it's a bit vague as to what they exactly recommend. But somewhere in that region is where they recommend giving a higher total dose, whereas the rest of the world, it's just to stick to the low total dose. Recently, in November last year, they've also provided a recommendation for giving a low total dose over 7 days. So there's lots of regimens, but which one should we be using? Unfortunately, at the moment, it doesn't really matter what in terms of the debate, because the vast bulk of countries are just using this same dose, this low dose over 14 days. But when it comes to what we should be using, and part of the reason that they're all using this is that we don't have good direct evidence. So a Cochrane review found that there was only 2 RCTs that they included directly comparing the low and the high regimens. So really, we're sort of at a loss as to which one, what the evidence is, what's the benefit of these higher doses versus the safety potential safety risks that you get with them. Because of this, we've taken an alternative approach to the standard approach. So rather than sort of putting together a massive clinical trial across all endemic regions in the world, probably have to enroll thousands of patients and cost tens of millions of dollars, we've looked at it from the 70 years of data, or essentially that we have to date, to try and determine what the effective primaquine dose is on efficacy, safety, and tolerability. And we've undertaken a systematic review. We've approached investigators whose studies fitted within the remit of that systematic review and collected the individual patient data, so the original data, and put that together. And we found of the 96 eligible studies, around about a third were able to get the data for. So that's around 8,500 patients from 19 countries. And you can see there the categories of patients according to whether they received primaquine or their total dose of primaquine that they received, low total dose or high total dose, correlating to those 3.5 and 7 milligram per kilogram categories from the previous table. So what about efficacy? What was the results? Well, for this group, we had just under 7,000 patients from 23 studies. And this figure here shows the risk of recurrence over time, up to 180 days. The black line is the risk of recurrence without primaquine, blue line with low total dose primaquine, and red line with high total dose primaquine. And it's pretty clear that giving primaquine is beneficial to not giving primaquine. So for example, the high total dose primaquine versus no primaquine had an adjusted hazard ratio of 0.1, which means that you really just need to treat just over 1 patient to prevent a single recurrence. Pretty good bang for your buck. What about high total dose versus low total dose primaquine? Well, for the first time, we were able to show that high total dose primaquine has what the actual benefit is. And so adjusted hazard ratio is 0.45. And this means that if you treated people with high total dose primaquine instead of low total dose primaquine, the number needed to treat to prevent 1 vivax recurrence would be 10 patients. We then looked at this in different smaller subgroups of patients. And perhaps surprisingly, we looked at it in the group of patients that where currently 7 milligrams per kilogram or higher doses recommended versus those that were not. So this is the first panel of this forest plot, relapse periodicity being low, which means that vivax does not relapse very rapidly in these regions, and that's sort of the rest of the world. So it's Africa, Americas, other parts of Asia, versus relapse periodicity being high, which is Southeast Asia, Oceania. And the benefit of high dose primaquine existed, again, compared to low dose, existed in both regions. It also existed across all age groups. So what dose should we use? Well, should we just take the the categories that have been given to us previously, or should we sort of reassess this and see if there's actually a better dose? We looked at the total dose of primaquine as a continuous variable rather than a categorical variable. And this figure shows the hazard ratio of recurrence with a reference of a primaquine dose of 2 milligrams per kilogram. And as you can see, as your dose of primaquine increases to the right, your hazard ratio falls until you get to around that 6 to 7 milligram per kilogram mark where it starts to plateau. And so basically 7 milligram per kilogram probably is the answer to the first question I proposed in the title. What dose of primaquine is best to prevent relapsing malaria? Unfortunately though, it doesn't take into account the side effects. And we need to consider gastrointestinal side effects, but we also need to consider hemolysis in particular. This can cause the major clinical concern for patients. So from a gastrointestinal tolerance perspective, a reminder that we're now talking about daily milligram per kilogram doses. We're talking about side effects rather than the total. And we've got, in this group of patients we analysed, we had around 5,500 patients. This forest plot shows symptoms on days 5 to 7, comparing different doses of primaquine to no primaquine. And you can see that all of these confidence intervals basically overlap, but there does seem to be a slight increase in patients that received a high daily dose of primaquine, so 1 milligram per kilogram of primaquine, but no difference in gastrointestinal symptoms or no substantial difference in gastrointestinal symptoms between low, intermediate daily dose primaquine and no primaquine. But what about hemolysis? Because this is the elephant in the room, and this is the reason that primaquine has not been introduced at higher doses. Clinicians are concerned, policymakers are concerned, everyone's concerned. Are we actually going to cause deaths through or severe events, hospitalisation, blood transfusions by giving primaquine to patients that shouldn't be getting it? This figure here is a plot of patients who are known to be what we call G6PD normal. So they're known to have a G6PD activity of greater than 30%. And it is a linear mixed effects model adjusted for the things mentioned down below that really compares patients that did not receive primaquine, it's the blue line, they received chloroquine only, compared to patients who received chloroquine plus primaquine at the red line. And I just want to point out a few things, and it shows this is the first 42 days after treatment. So what happens initially is their hemoglobin falls, and this happens in all patients, irrespective of primaquine, and it falls actually to the same amount, and this is based on a population-based curve. So on day 2 to 3, you get an nadir, and this is because there's a hemolytic effect of having malaria. It then rises back up, but importantly, it continues to rise where it starts to plateau as compared to starting to plateau in patients that have primaquine, because patients who have primaquine are not going to get another recurrence or are less likely to have another recurrence or another relapse. And so there's not that downward pressure on hemoglobin that you get in patients that are going to have another relapse. So that's reassuring. What about doses of primaquine? Is there a dose effect of primaquine that we're not seeing as part of this curve where we just split into no primaquine versus primaquine? Well, Meg Rajasekhar led this work, safety study group of 16 studies, and you can see that these are adjusted values of hemoglobin and day 2 to 3 for the population, and there is really no effect on primaquine dose versus no primaquine. Again, reassuring. But again, it's all based on the population. So what happens if we've got outliers? What happens if there's a small group of outliers that are not picking up in some of these groups? I think everyone would agree that a fall of a quarter of your hemoglobin, less than 7 grams per deciliter, which is a cutoff that we often use to give a blood transfusion, is a bad thing. And so we're looking at these severe events now by these 4 categories. And you can see that one person who did not receive primaquine had such a fall, and there were also 4 people in the intermediate daily dose category and 6 in the high daily dose category that had falls like this. Unfortunately, these are all unadjusted. I'm going to say fortunately because they're such small numbers and so the events are so rare, but they are unadjusted because we don't have power to be able to adjust for these values. So just going back to G6PD deficiency, primaquine radical cure without G6PD deficiency would be pretty straightforward. Unfortunately, it's meets it head on, and we really need to address it. So G6PD deficiency is a very common genetic condition in regions where malaria exists, potentially because it protects against malaria. It's an X-linked disorder, which means that males can be normal or deficient, and by deficient I mean less than 30%. By normal, we usually say greater than 30%, but there is a third category in females, because females can have one copy of the gene and can be heterozygous, have intermediate activity between this 30 to 70% mark. And there's considerable concern that heterozygous females or intermediate patients with intermediate activity may actually have a higher risk or do have a higher risk of hemolysis than those who have normal activity. So can we use all of the same regimens in this group of patients? This is a plot of G6PD activity as a continuous measure now on the x-axis versus your day 2-3 hemoglobin, again adjusted for a bunch of things. And the point of interest that we're really interested in this is this 30 to 70% group. And you can see that it is correlated. G6PD activity in this group is correlated to the day 2-3 hemoglobin. So there does seem to be an impact of a lower hemoglobin on day 2 to 3 after treatment as your G6PD activity falls. If we take this group of 30 to 70% G6PD activity and focus in on it now, so a different scale on the x-axis, and look at the actual raw values of patients, I don't want you to take too much away from this other than to see a couple of things. One, that there are very few patients that we have data for in this group, despite there being 1,600 odd patients in the figure on the left. Two, the patients have different types of circles. Male circles are closed and female circles are open. And we can use these data points to try and narrow down on the severe events again. So the same severe event as the previous slide, looking to see who actually had these substantial falls. No patients who are male had such an event, although very small denominators. And 2 patients who were female had such an event, and both of them received this high daily dose primaquine, although both of them were also from the same study. And we do need to note the very small number in the denominators. So what can we say from this? Well, we can say that high total dose primaquine is more effective than low total dose primaquine in many regions. And this is reassuring for Australia, for example, because it is standard treatment to use high total dose primaquine in Australia, so 7 milligrams per kilogram. And it's standard treatment to use it in other countries where routine G6PD testing is available at the 30% threshold. We can now quantify the benefit of this over low dose. So it can suggest that the high total dose versus low total dose reduces the risk of vivax recurrence by 55%. Interestingly, as we're aware, there is regional and individual variation, and it's probably some of this variation that's overcome by increasing the total dose to 7 milligrams per kilogram over the low total dose, especially in regions we weren't expecting there to be a benefit. So these regions outside of Southeast Asia and Oceania. And that's probably because high total dose potentially overcomes some of the other issues with primaquine, so it potentially overcomes poor adherence, or genetic factors that mean that less primaquine metabolite would be active metabolites, which is related to CYP2D6 in the liver. From a safety perspective, there was no increased risk of hemolysis in primaquine, with primaquine in patients with greater than 30% G6PD activity at a population level. And we can narrow this down so there was no increased risk of severe events in patients with 30 to 70% activity treated with the 0.25 or the 0.5. That's the low and the intermediate daily dose primaquine. But there was increased hemolysis in female patients at 1 milligram per kilogram per day. Again, noting a very small denominator for all of this for patients in this last statement. So thank you very much to everyone that's been involved in this work, in particular to Meg Rajasika, Rick Price, Julie Simpson, Peter Edler, who worked with me on it, but also all of the individuals who contributed data undertaking the original studies. And I'll open the floor for questions.
So just checking first if we've got any questions in the room for Rob. Great, we've got one. Anna, I'm not sure, Rob, if you'll be able to hear the question when Anna asks, so I can repeat it.
No, are the ceiling lights on, you know?
I can hear you, Anna. I can hear you just. So give it a go and we'll see.
Thanks, Rob. That was great. Really clear presentation for complex concepts. In terms of what the mechanism is of drug-induced hemolysis for those G6PD deficient individuals, is there any pharmacotherapeutic research going on to block that hemolytic effect?
Really good question. So in terms of the oxidative metabolism, there's a few different groups that are working on this, but to be honest, it isn't something that has been considered substantially in the vivax field. There's a red blood cell biologist who is working on it in Pennsylvania, who I've had a little bit of discussion with, and they've got some agents which show some promising effects in mouse models. But it's a bit unclear whether exactly how many pathways are involved in this and exactly how many pathways will potentially need to be blocked or affected to achieve that. And then there's also other groups that are looking at methylene blue, or hypothesize that methylene blue, I should say, may actually be able to do something along those lines. But it's really in its infancy, and despite having used these drugs for so long, we've got so few active drugs that we can use and very little research in that specific area. I think it's something that probably is for the future. Everyone's tried to work out how to use the drugs better to reduce the hemolysis, but not actually how to prevent it in the first place.
Another question in the room?
Rob, it's Alan. Thanks for that presentation. Is there concern about emerging resistance to primaquine? And when you talked about the common treatment guidelines suggesting low dose over 14 days, which you've shown have higher rates of relapse, I suppose if there's inadequate treatment and perhaps lower adherence to treatment over 14 days, might that be contributing if there were that concern?
Yeah, so I guess from a primaquine resistance perspective, there's never been any proven evidence of primaquine resistance. We know that vivax parasites, there's different phenotypes of vivax parasites. So parasites in the Indian subcontinent are certainly more sensitive to primaquine than, say, the Chesson strain or in our closer neighbours. And it may well be that you need a lot more primaquine, even more than that high total dose in, say, Papua and PNG and some of the other Pacific or oceanic countries. Sorry, Alan, what was the second part of your question?
I suppose it was, well, if there isn't really concern about emerging resistance, maybe it's not active, but whether the higher dose, shorter regimens might be, which have shown are more effective in preventing relapse, might then be less prone to leading to emerging resistance.
Yeah, it's interesting. I think it's certainly a possibility because I suppose the longer your exposure, the more likely it would be to develop resistance. Saying that, because we haven't had any evidence of resistance over the 70-odd years, it's probably less of an effect. I think the bigger issue is actually that the longer your regimen is, the less likely people are to take it. People have acute clinical malaria. You treat that acute clinical malaria, their symptoms get better within 2 to 3 days. They're unlikely to complete, well, we know if they don't take a 14-day course. And so because of that, it's better to shorten the course. The difficulty with that, of course, is that as you shorten the course, the side effects become more of an issue, and in particular, the risk of hemolysis. So it's really this balance. What I haven't talked about is that there's this other drug, tafenoquine. It's single dose, which sounds great, but it is a really interesting drug. It's a prodrug, and it has a prolonged half-life. So really, really long compared to primaquine. So once you've given it, you can't stop it. You can't take it away. So if you do induce hemolysis in someone, then you're potentially in trouble. Whereas with primaquine, if someone clinically starts to develop signs or symptoms of hemolysis, then you can stop it. And because of that, the cutoffs for tafenoquine have been set much higher. So you have to have greater than 70% G6PD activity. It's really in its infancy in terms of implementation, but there's a large-scale implementation study in Brazil at the moment, and being considered for the guidelines there. And it's also required the introduction of point of care G6PD tests, which have not really been available until very, very recently. So there's sort of a whole other aspect that's happening from the tafenoquine angle. I don't think tafenoquine is going to solve all of our problems though. And so I think primaquine is still definitely going to be in use for a long, long time.
It looks like there's some questions online. Nick, you might have had your hand up.
Yes, thanks a lot, Rob. That was that's fabulous overview of the primaquine dosing. I'm just thinking back to Malaysia, where we witnessed sort of the elimination of vivax malaria during our time there, and there was routine testing at a 30% level for G6PD, and routine dosing with the higher dose of the primaquine. And they've eliminated it. Of the remaining countries where vivax is endemic, how many of them have routine institutionalized G6PD testing, even at the 30% level? Because obviously they'll have to have that sort of testing to implement the the recommendations arising from your data. And of those that don't, what's the likelihood in the next year or two of routine implementation of G6PD testing in those countries?
Yeah, great question, Nick. I can't put an exact number on the first part of that question. So how many actually implement it? Kamala may, who I know is in the audience, may be able to give a more exact number, but I'll throw to her in a second on that. But certainly this new point of care test, the SD biosensor, quantitative G6PD test, has meant that there are more people or more countries taking this up and are able to actually do point of care G6PD testing, because there's no point in previously people essentially had to go to a sort of a tertiary centre where they did specific other testing for G6PD to be able to do this, which is pretty hard in the field where the vast bulk of people are going to be a long way from the healthcare system in the far corners who have malaria. So you really want to try and do it out in the field as much as possible, or as far as far out in the field as possible. So, and I think there's 3 or 4 countries now that have taken up that SD biosensor test in the Asia Pacific region that I'm aware of, but Kamala may be able to give a little bit more detail on that. So there is hope, I guess, for doing that, and hope for being able to use a higher dose if we can actually identify patients, because there are countries that don't test for G6PD deficiency and still give primaquine. And obviously, if you were doing that at the higher dose, then that would be more concerning.
Just checking if you're happy to answer the next question. I want to take it on notice.
Yeah, sure. No, I'm happy to jump in. So yeah, I mean, most of the Asia Pacific countries have some reference to testing in their guidelines, but in terms of implementation, that's still a while to go. But yeah, as you said, Rob, biosensor, which is this new or fairly new point of care test, is been implemented across the Mekong in Vietnam, Laos, Cambodia, Thailand, and Solomon Islands have just started implementing as well. And that's all done in the context of preparing countries potentially for tafenoquine use, but we'll have obviously a lot of opportunities for better primaquine use as well.
Just checking before we wrap up, do we have any more questions online? Doesn't look like that's the case. Thank you very much, everyone who's come along today. Thank you very much to Dr. Rob Commons for presenting, and for everyone who's joined us online. And we look forward to seeing you at our next research seminar. Thanks, everyone.
Thanks, Jennifer.